I'm delighted to be virtually here with you, although it's a little early here in Alberta, but that's fine. I'm happy to present it. It's a little stressful for me to present your last grand rounds of the year, so I need to leave you with a good impression for you to have a nice summer. Anyway, I will do my best. And as Professor De La Hoz said, my presentation is called From the First Clusters to Long COVID Rehabilitation, an Academic Occupational Journey through the COVID-19 Pandemic. It's going to be, when Raphael asked me to present, and he suggested that I would present on COVID, and I've been doing quite a bit of research on COVID. I realized that I've never been invited to talk precisely on this topic. I give a number of presentations, and in many occasions, I have the opportunity to talk about work-related mental health or other topics, but not COVID. So it was a good opportunity for me to pause, sit, and reflect on all of the different stages of the research I've been involved in with regards to COVID. So this is what I'm going to present, and I'm going to get started with the typical disclosures. Mostly public affiliations, public grants. The only additional money that I get is from OEM, a small honorarium for my participation as an associate editor for this journal that everyone in the call probably knows. So I'm going to get started with, I won't say that preparing for this presentation brought back some PTSD or anything, but I was willing to think as to how I got involved with COVID. And the earliest memory that I have is really this picture here at the bottom left of the slide. So you might remember that early in the pandemic, there was a phase where I was not really sure what was going on. I was like, probably like a lot of people, the people are exaggerating. It's not going to be that dire, and it's going to be fine. But really, I remember the day where I kind of changed my mind, and it was kind of an on-off thing. And I realized how serious it was. And I was in Canada already at that time when I saw those pictures from Lombardia and Emilia-Romagna in Italy, where they pronounced a lockdown. And as their government in Italy said that those provinces of Italy would be in lockdown, people started to escape and were rushing, like running in train stations to try to catch trains to escape from those areas that would be in lockdown. At that time, I was like, we're in a movie. That's not the reality. And that's when I really realized how serious it was. The thing is that, as Raphael said, I was born and trained in France, and I moved to Canada in 2019. So it was not even a year when COVID started that I was in Canada. So I still had very, very strong connections with France. So the thing is that I experienced the pandemic twice because, and you see this on this curve, the number of cases at the very beginning of the pandemic was very different from one country to another. It really spread from one place to another in different stages. And France was earlier than Canada. There were maybe 10 to 15 days between the two countries. If you like, there's a lot of lines on this graph, but the France is the blue one. So you see those are absolute numbers of cases, sorry, per 100,000 inhabitants. You see here how it rises in France in the second half of the month of March of 2020. And in Canada, it's a little later, like it's maybe 3 weeks later. So everything that I was experiencing in France, because I had so many connections, I was feeling this and reporting this to my colleague in Canada, who were starting to see me a little panicking or being very concerned. And people were that there was a discrepancy because they didn't have the knowledge of whatever was going on in French hospitals. And then 15 days after everything that I said, this is going to happen. There's going to be, a lot of restrictions. It's going to spread. It happened, but 15 days afterwards. So I had kind of, the pleasure of experiencing this pandemic at the beginning twice. Everything happened twice for me. So the thing is that I was, I'm an occupational medicine specialist. I was not called to help in the wards, or even though we put our names on rosters to be, the third line roster of, people being able to help in GIM wards or whatnot. But I've never ended being called to help and help in hospital wards. But the thing is that, in this situation, I was willing to contribute and do stuff to help. So I tried to do my best, and I'm going to explain you from the start, the beginning of the research I've been involved in up to date. And when I was thinking about it, I was able to separate and identify three different phases in my contributions to COVID research. So the first phase is really starting with scoping reviews and contributions with the Oxford collaboration. And I'm going to explain this. The very first paper I've been involved in with regards to COVID actually was published in French. And it's a very interesting paper. And I have to pay tribute to Jean-François Giano, who's a full professor of occupational medicine in Rouen University in France. And it was really early in the pandemic, the very first month of the pandemic. You see that it's been published in April of 2020, and it's been peer reviewed actually. So you can imagine that by the end of February, early March, we had something to submit to this journal. And the paper is called Evidence for Possible Airborne Transmission of SARS-CoV-2 in the COVID-19 Crisis. Like retrospectively, it's really interesting how early we were compared to a lot of dominant thinking to start thinking that COVID could be airborne. That was the very first paper I've been involved in. I insisted that we published an English version because not everyone reads French. So it was published in a shorter version in OEM in form of a letter, much more condensed. The full paper provided a lot of arguments to explain why COVID could be at that time. It was just a hypothesis, but it was a strong hypothesis, and there were lots of arguments. So we published this, but as you remember, there's been an enormous pushback from ID and ICP specialists, really denying the airborne transmission, sometimes with very violent messages that we got through social media saying that we were nuts and we were like ridiculous, claiming that it would be airborne. And they were really focusing on droplet and hand hygiene measures. So there were some tensions between ICP specialists and occupational health, some tensions that, interestingly, Ivan Ivanov from WHO, who is one of the team leads with occupational health at WHO, during the 2022 virtual ICO conference, he took the floor and spoke, and he recognized that those tensions didn't help workers' protection all in all. A little later and more recently, Trish Greenhall has elaborated on this and said that the denial, what she really called the denial of the airborne transmission, has really been an issue. And she outlined that in November of 2022, W's outgoing chief scientists reflected that the organization's greatest error in the pandemic was to deny early on that the virus might be airborne and design a global strategy around an assumed droplet mode of transmission. An alternative explanation, which has extensively been discussed in the peer-reviewed literature, is that dominant voices in the infection prevention and control community did not grasp the basics of airborne transmission and failed to listen to people who did. And we were part of people who were trying to tell that it was airborne. So I'm talking about Trish Greenhall, who is a full professor of medicine at Oxford University, because she, at that time, Twitter was a place where it was possible to go without getting too crazy and having to deal with bots and all of the nightmare that's going on Twitter. So it was really a tool that was fostering collaborations. We were sharing knowledge, we were sharing papers, we were sharing reviews, and we were creating teams and connections. And it's exactly what happened early in the pandemic. Trish was very active on Twitter. Now she's on Blue Sky if you want to follow her. And we ended up being connected and creating a group with the composition of the group on the right-hand side of the slide to discuss rapid reviews and scoping reviews, especially for primary care, because Trish is a professor of general practice, she's a family medicine specialist by training. So we set up that group and we've been meeting every single week during month early in the pandemic. And this led to a number of topics that we've been working on and great literature publications as well as peer-reviewed papers. So the Gray literature publication ended up being published on the CEBM website. CEBM is standing for the Oxford Center for Evidence-Based Medicine. You can access this website. These rapid and scoping reviews are still on the website. And I'm going to discuss some of the peer-reviewed publications. The topics that we've been dealing with really were provision of PPE in general practice, whether we were talking about eye protection, shoe protection, clothing, and face mask. And it's been published in the British Journal of General Practice with Kamlesh Kunti as a first author. I've been particularly interested in meatpacking factories. I'm going to explain you why. And we ended up publishing something in the Annals of Work, Exposure and Health in 2021. And we've been looking into aerosol generating procedures. You might remember that there's been a lot of discussions about whether or not aerosol generating procedures would be a problem and how we needed to mitigate provision of care to patients who needed it with the additional risk that those procedures might provide. But this was with the assumption that still droplet would be a transmission, a dominant way of transmitting COVID. But as soon as it became clearer that the transmission is dominantly airborne, this topic of aerosol generating procedures was a little less of interest. Anyways, we had the opportunity of looking into that topic and wonder, okay, people are talking about aerosol generating procedures. Why? How do they classify those procedures? What is said? And this scoping review, which was published in the BMJ Open Respiratory Research, was really trying to look at those AGPs, taking recommendations from scientific societies all around the world, in looking into it and classify those. What do the ENT Society of Canada say about nasoscopy? Is it generating aerosols or not? So we were able to classify those and see whether or not there's scientific rationale. Not surprisingly, this classification is quite arbitrary. There's very poor scientific rationale in this classification. And more surprisingly, there's a lot of disagreement. So for some of the procedures, there are procedures in which we were able to see, yeah, okay, there's a high degree of consensus across scientific societies for procedures such as autopsy, intubation, extubation, bronchoscopy, cardiopulmonary resuscitation, and so on. There were 14 such procedures. And there were procedures for which there were like disagreements. And some would class that as aerosol generating and some wouldn't, such as dental procedures. It was really a question because like dentist was a whole word of healthcare that was impacted. Is each generating procedure? There were disagreement on this. Upper GI endoscopy, thoracic surgery and procedures, nasal and oropharyngeal swabbing. And up to date, this is now my most cited paper. It has generated a lot of interest. Reviews are usually like have a shorter time lifespan in terms of citations, so it's already going down. But still, it's over 100 citations for this paper. So as I told you, I got interested in meatpacking factories. Back in the days, early in the pandemic, in say April or May of 2020, in Alberta, which is the second province in Canada from the west, a quarter of all COVID cases, 25% of every single COVID cases, you take 25% of those 25% of cases were attached to one cluster related to a meatpacking factory close to Calgary. And actually, one of the very first workers who died in this cluster was Hiep Dui, the woman who is on the slide here. And we were really wondering why it looked like that the meatpacking factories had a higher risk of having COVID clusters, because the problem was not just in Alberta. We had also COVID clusters in meatpacking factories in France as well. So we looked into it and tried to formulate hypotheses. And we were able to gather different topics and different paths to explain why meatpacking factories were at higher risk of having COVID clusters. The industry in itself was at risk. It was considered as a essential business sector. So work was absolutely not disrupted during COVID. Things kept going as business was carried almost as usual. There were a lot of business pressures because workers were told they were essential, that what they were doing was important. So there were pressure on them to keep on going. The workforce particularly was vulnerable in the sense that a lot of workers in the meatpacking factories are migrant workers, sometimes not speaking good English or good French. So they were not able, for some of them, to get the information from the chief medical officer of health directly from them. The chief medical officer of health was speaking almost daily, providing information, updates to the public health regulations and recommendations. So there was a lot of communication, and everyone basically was listening to Dr. Dina Hinshaw at that time, our CMOH in Alberta. So a lot of those workers were just not able to understand what she was saying. So workers were getting some information through their managers, but there was some, distortion in the message, and sometimes it was kind of redirected towards production and not so much towards protection of the workers. Those factories were not really located downtown Calgary. Like you're not gonna have a meatpacking factory close to the Saddle Dome in Calgary. That's outside of town. So you need to have transportation, and workers sometimes share common transportation, couches or buses to get to the factory where it's packed and overcrowded. Sometimes they share also the same accommodation, dormitories, and they would also transmit COVID one to each other through those overcrowded transportation and housing. And there was kind of, not so much of a strict regulation that was not so much strictly applied also, and a lot of political pressures. On the left-hand side of the slide, I found something quite interesting. It's a table that was published in 1985. So it's definitely, we're not talking about SARS-CoV-2 that was not even existing at that time, but it's data about another coronavirus, coronavirus 229E, for which I was able to find a publication talking about the stability of the virus depending on the temperature and the relative humidity. And you can see here that the best scenario for the half-life of the virus is really when the temperature is low and when the relative humidity is high. You see, you have the best numbers for 6 degrees. We are talking in Celsius here in Canada, so I have no idea as to how many Fahrenheit it is. And it's more than 102 hours of half-life when you have 6 degrees and 50% relative humidity, as opposed to way less when you have higher temperature, for instance. And really, it looks like the kind of conditions you have in the meatpacking factories, low temperatures and very high humidity rates, which is good for virus persistence. So we were able to take this proxy to kind of make assumptions about this. Remember, we're early in the pandemic. We are in April, so we have basically nothing about COVID in itself that's reliable. we're able to publish this a year later, as I told you. I got interested in another population of worker. If you remember what I said about AGPs, the first procedure on which people agreed that it was transmitting aerosol was autopsies. So when you extrapolate, yeah, autopsies, dead body, funeral service workers, people were dying during COVID, and we were thinking a lot about healthcare workers, but not as much as not as much of the other business sectors that might be impacted with all of the disruptions happening during the pandemic. Funeral service workers were a population where they had more work and also they had more risk because if someone died because of COVID, there might be some transmission. So I tried to set up a study trying to reach out to funeral service workers associations. And it was really a researcher-driven initiative. They didn't get in touch with me. I was interested in this, so I tried to get in touch with the National Association of Funeral Service Workers in Canada and connecting with the Canadian associations in every province and colleges who were training those funeral service workers. So I set up a bilingual study, ethics. So when you do a bilingual studies with ethics in a bilingual study, you have to write your material twice. So for those who've been writing ethics application, you realize how painful it is. So you have twice the pain. But the participation was really disappointing. We ended up just having 58 participants between May 15 and July 31st, 2020, with discrepancies across provinces, meaning that some associations have been more active in sharing the information and some less active. So it was also a learning experience for me that, when the research is researcher driven, it can fail if there is no clear worker interest. But anyways, we got very limited information on COVID, and what we were able to see is that they had higher levels of anxiety, depression compared to some occupational groups, and that women in the field were more overcommitted than men. We've been able to publish this in JOEM, and people sometimes cite this paper, which is far from being my best, but it was kind of a learning experience for me that, getting a better worker involvement is key to have a better participation. So now moving on, it's not because I said that we needed to be interested in non-healthcare workers that I had no interest in healthcare workers. I definitely had. And a huge part of the research I've been involved in during the COVID-19 pandemic was in a cohort study led by Nicola Cherry. I think that some of you might know her. Nicola Cherry was a full professor of occupational health here at the U of A. She just retired, but she's been involved in this study that she set up with some federal funding from a group from the CIHR, the Canadian Institute of Health Research, created a fund dedicated to COVID research, and we got some money from this federal funding source to run a multi-provincial study. Here on the slide, you have all of the people who were involved in this multi-provincial study, and we've been recruiting healthcare workers in 4 provinces. British Columbia here, West Side, Alberta here, Ontario, and Quebec as well. So again, we had to do everything bilingual. So here is a simple representation of whatever we've been doing. I'm going to explain you step by step. We're going to first look at the middle arrow here, where you have phase 1, phase 2, phase 3, and phase 4. So we started to run a study. We've recruited almost 5,000 healthcare workers, physicians, nurses, healthcare aides, licensed practical nurses, personal service workers, and those were recruited through their colleges. So for physicians in Alberta, through the College of Physicians and Surgeons of Alberta. Those are the licensing authorities, and those were our point of contacts to recruit directly healthcare workers. We have sent to those recruited healthcare workers questionnaires in different phases. So we did phase one with a first batch of questionnaires sent in spring of summer of 2020. And we did this repeatedly up until spring and summer of 2022. So we were able to get longitudinal data for those 5,000-ish healthcare workers. For some of them, and that's I'm gonna go up in the screen, we were able to get consent to link their questionnaire to their health records, and we were able to do so in Alberta, where we have a provincial healthcare system. It was possible to cross the data together and to do data linkage with data sets from the healthcare system. So for some of those healthcare workers, those based in Alberta who gave consent, we were able to do a matched cohort of Alberta healthcare workers, and we took community reference to do a case control study for this part. And furthermore, we did two additional nested case control studies. The first one that we did is below, where when we started to get COVID cases within our 5,000 healthcare workers, we asked them to tell us, and we asked them a specific questionnaires to them, and we matched those cases to four controls from the cohort. So we had like in early 2021, say a nurse from the cohort was getting COVID. We were submitting a specific questionnaire to this nurse and recruiting four persons from the cohort and giving them a questionnaire, four persons that didn't have COVID as controls. So that's the nested case control study. And the last one is a nested serology study, for which we asked a study participant to agree to give us blood samples, and we were able to measure antibodies for COVID, and we were able to get serology testing, which was arranged in every single province. So that's overall what we did over 2 years of the study. This led to all of those peer-reviewed publications. So we first described the cohort. So that's just explaining in more detail what I just described. This is in BMJ Open. One of the first paper was the nested case control studies, the study where we identified the cases and matched to the four controls. So this allowed us to identify risk factors for COVID for healthcare workers. Then we looked into determinants of sickness absence, and we found that vaccination is related to shorter sickness absence. In the matched cohorts in Alberta with the healthcare workers and community persons, we were able to say that healthcare workers were at increased risk of COVID-19 and were having a worse mental health compared to community controls. We looked at the IgG response, and we were showing that lower anti-RBD IgG levels in healthcare workers were found in persons presenting with MS, rheumatoid arthritis, or taking select medications, usually immunosuppressants, basically. We've been looking at in-work characteristics, supports, and mental health, and we were finding that healthcare workers working directly with COVID patients had higher anxiety and depression levels. We looked into mental health supports quantitatively and qualitatively. We had two papers about it. 94% of healthcare workers had access to mental health support. That is the same old story. Workers, when they have supports to help them with psychosocial risk, it's always in getting additional support system such as EAPs, calling the psychologist and so on. Rarely acting on demands, which is what works best in terms of psychosocial risk prevention. But still, almost everyone has had access to such support. Half of them used them, and 25% of those with HEDS scores, so the most depressed, used no support. We looked into long COVID in the cohort, and it was the master's degree dissertation of our student, Tanisa Dunajski. And the numbers that she found were kind of similar to what we had in other publications. 27% of the almost 1,000 healthcare workers who tested positive developed long COVID. So it was 5% of everyone. And within them, 8% had severe long COVID symptoms. So really long COVID was not so much of a very frequent phenomenon. We were able to show that it is quite rare, even in very exposed workers. Uh, and then we looked into the evolution of stressors in the court. This paper was the one I've been more involved in. I was the corresponding author of this one. And we've been looking into how workers were self-reporting stressors. So you remember we had 4 questionnaires, and in each one of those questionnaires, there were free texts, but free boxes, like, workers were able to say, writing down what they were thinking. So that's the problem. When you run a study with free text, you have to do something with it. And it means that you have to go through every single of those comments. We had more than 15,000 such comments, 16,786 precisely. And you had to code them to find, different themes across them and to, count them. You need to do something. So this is what we did in our team. I've been more involved in the French-speaking ones because I'm speaking French, and some of our research assistants did a lot of work with this. And I've been working a lot with my colleague France Labrèche, who's been very, very hardworking on this paper. And it was great to work with her. It's one of the top occupational epidemiologists here in Canada, working in Quebec. So what we found is that there was an evolution in self-reported stressors across the different phases of the pandemic. So there are things that went down, that improved over time, and things that got worse, that that deteriorated over time. So we found a number of factors. I'm not listing you everything, but you see that, for instance, things such as fear of COVID went down when you look at the all odds ratios. It's really going like significantly down. You see, like if you take phase 1 in each situation as a reference, so with an odds ratio at 1, you see that by phase 4, you are 20% of that. So that's decreasing significantly and with a huge magnitude for this one. Problems with PPE was really early on, and we've shown that really it's been corrected over time, and people were not complaining so much about PPE provision. It got better. At the beginning, there were shortages of everything, remember? So that's very interesting to see this. Virtual healthcare. It's interesting to see, how quickly we've been able to adjust. For instance, myself, I don't know if it's the same in the Icahn School of Medicine for your practice. Before COVID, my amount of telemedicine and teleconsultation was zero. I was never doing this. Even though we had patients, living 5 hours from Edmonton. You see, Alberta is big, so people were coming in person, and we had our clinics in the early afternoon precisely for this reason, because if people needed to travel 6 hours to come, they need to get up early. So that was the reason why we had our clinics in the afternoon, which we still have. But when it was COVID, we shifted to telephone consultation. Like immediately, our IT systems, our electronic medical records were electronic, as the name suggested it, and it worked fine. And even since COVID, now I'm keeping a portion of my clinics virtually, especially for patients that are coming from very far away, to save them transportation and for, environmental concerns and safety concerns. Driving in Alberta in the winter can be difficult sometimes. But still, we see here that people got used to virtual healthcare. At the beginning, it was a stressor, and then it went down as well. It's also a suggestion that when you consider a stressor in the workplace, it is likely to be dynamic. You can't say, virtual healthcare, electronic medical records is a stressor once and for all. No, there's a process of adaptation from the worker to the system, and the system is adjusted based on the worker's need. I'm not expanding on this, but there is this kind of circular relationship between a worker and a tool in the movement that's called instrumentation and instrumentalization. That's kind of a circular relationship that is true for IT tools as well as, physical tools, workbenches and hammers and whatever. It's kind of the same thing that happens. And not surprisingly, there are things that also got worse over the pandemic. Poor behavior. Healthcare workers complained much more about poor behavior of patients and coworkers during the course of pandemic, and the volume of work went up to a really concerning extent. It almost doubled when you look at the odds ratios in early 2020, and you look at the same odds ratios 2 years afterwards, 1.89. Like it's kind of skyrocketing in this time period. So now, moving on to the last phase of what I did with COVID, I've moved to long COVID work, and I'm going to get started with talking about the ACOEM guidance statement, on which I've been working along with someone you know very, very well, Ismail Nabil, and Greg Stav, who really did the heavy lifting of this. Like Greg has been incredible working for this. I really feel like I've not done much of this because really our two other colleagues have been working so much on this. But still, we have this ACOEM guidance statement that's available, that's helpful. You can refer to it. It's a very good overview of long COVID. What's very interesting is how we found similarities with other post-infection syndromes, and how similar we found similarities with infections with EBV or Coxiella burnetii. There are elements to help you provide some arguments for in situation where you need to argue for workers' compensation, to build up your causation analysis paragraphs in your reports, and also recommendations for vaccination. This has been published by the GOIM, of course. I've also been involved in work here at the U of A with the rehabilitation medicine team, especially on the long COVID side. So I've been involved in a conference that was gathering researchers, healthcare workers, as well as patients, which always brings an interesting perspective. When we involve more patients, we get to different concerns that are less medical, less on biology and physiology, but more on day-to-day hurdles that patients are experiencing. And all in all, we've been identifying that a lot of insurers and workers' compensation boards, just for the record, workers' compensation in Canada is not private. Like in the US, it's public. There's just one compensation board in Alberta, for instance, and in each province. The coverage of workers in Alberta for workers' compensation is almost 80% of the entire workforce. And we're probably one of the provinces with the lowest coverage rates. Some provinces are 100%, some are in the 90% range. So really 80% is almost the lower end of workers' comp coverage. This gives you an idea as to how prominent workers' compensation is in Canada. But they're still acting as insurers, right? Workers' comp has no interest in paying premiums to workers forever. They're always pushing workers to return to work, and there's a lot of discussion in occupational medicine here as to how we need to speed up always return to work for every situation. That's true for low back pain. There's evidence that we need to speed up return to work for low back pain. But the problem is that we extrapolate those findings to every other condition. And in COVID, that's not so true. So we've tried to call for calming a little bit, like stop putting so much pressure on workers with set deadlines to go back to work. It doesn't work. And we also identified some issues with enforcing the duty to accommodate. In Canada, in most provinces, this is provincially regulated. There are human rights covered by Human Rights Commission, and under human rights, you can't discriminate anyone in workplaces based on their health condition, and you need to provide accommodation up until undue hardship. This is poorly enforced. And when businesses say, "Oh, we're going to bring everyone in person in the office," even though it had no impact on production, there is no one's enforcing and asking, is it causing undue hardship to the business that workers are working from home? And some of the long COVID patients really benefit from working from home. They can take naps, they can, relax whenever they please. It facilitates their return to work and the fact that they stay employed as opposed to getting out of the workforce. We have to have in mind that a couple of weeks ago, something very important happened at the International Labor Convention. The ILO, the International Labor Organization, has adopted the C-192 on biological hazard, a convention. So convention, as you may remember, is a very strong normative text because member states ratify it, so they have to sign. They can opt in or out. So now, like the text is up for ratification. So member states are going to decide whether or not they ratify this text. But once it's ratified, then it automatically becomes part of the national law. So it has to cascade through all of the levels of jurisdiction within a given country. So now ILO is pushing for more protection of workers with regards to exposure to biological hazards. This is really connected to what happened during COVID. There is a convention and there is an accompanying recommendation. Clearly, ICO has pushed a lot behind the scenes for this convention. And one very important paper has been this one from Yuka Takala, the past president of ICO, along with my colleague and good friend Alexis Descatas. They've been working on those global estimates on biological risk at work, which has been a key paper to push for this normative framework to be adopted at the last International Labor Conference. I hope that it will still have some relevance to the United States in the future. But that's a very important thing that's going to advocate for compensation of workers and protection. And finally, we've been also looking into there's things that we can do with regards to long COVID and rehabilitations and things that we shouldn't do with regards to long COVID and rehab. And our colleagues from the team of rehab medicine here at the U of A have been leading a scoping review to which I helped a little bit with regards to this. So what's important is that we shouldn't recommend aggressive rehabilitation. And in this sense, it's very different from what we recommend for low back pain, where we say move. Your like pain is gonna go away if you move. You can't stay still. You have to get muscle. You have to be active. Like that's what we'd say to patients with low back pain. And the problem is that, again, we try to extrapolate this to everything and to be in the speech that, yeah, you need to be active. So you need to go back to work as early as possible because it's going to be good for your health. Calm down. It's not so true with long COVID. Resistance training, aggressive exercise is going to provide bigger crashes. Long COVID patients, if you've been meeting with such patients, almost all of them are going to tell you, I have crashes, drops of energies at some point, and it takes time for them to recover. So providing them with resistance training increases the risk of prolonged recovery setbacks, and interventions ignoring post-exertional malaise risk to worsen fatigue, risk to reduce the effectiveness of rehab, and delay return to work. Another thing that workers' comp may not like is that digital or unsupervised treatment is not recommended. I don't know how it is in New York, but in Alberta, workers are paid for 12 sessions of physio, and after that, they're expected to carry on with the exercises that the physiotherapist has provided to them. So they are expected to do unsupervised physiotherapy based on the 12 session they've been paid for. We don't recommend this for COVID. Unsupervised treatment is not recommended. Excessive outcome measurement, we do like in occupational medicine, try to make things objective and have FCs with very limited evidence that it brings any benefit to the workers. Same for long COVID. Metrics are not good. It's not a problem of capacity. It's a problem of tolerance when it comes to long COVID. And by definition, tolerance is a subjective phenomenon that's playing a huge role in fitness for work. So that's the limitation that we have. I'm going to wrap up with this presentation with something that's a little aside with COVID, and that's media training. Because during COVID, I had the opportunity of talking to media quite a lot of times. That's the benefit, I would say, of being a French-speaking physician in a province that has, what, 4% of people speaking French in a bilingual country. So at the end of the pandemic, Radio-Canada, which is the francophone equivalent of the CBC, they have my phone number, they have my email address, and they were able to contact me quite a while. So I had to learn how to respond to interviews on the go. I didn't have any media training, and I did this in French, which was okay, but at the beginning, but quite hard, and in my second language, which is English, which at the beginning was quite hard. But you get the trick, you get some incorporated knowledge as to how you need to respond to questions. When you respond to an interview, you have to try to finish your sentence even before you started it because you're always too long when you talk. There are tricks like this. But the thing is that you get some solicitations. You have to adjust because at some point, people are reaching up to you for questions that start to be outside of your area of expertise. Like, for instance, recently they were asking me to talk about vaccination for polio, for instance. This is absolutely outside of my expertise. It might be tempting, for your ego to say yes to everything, to be on TV. It's nice, but I think it's really important to be responding to media requests but precisely for your expertise because it's easy to say very common things that might end up being wrong. And also I take this as an opportunity to make occupational medicine visible. That's really my first goal when I accept those media requests is to help our specialty be visible. Each time I insist that I should be presented as an occupational medicine specialist so people understand that what we do, and this is something, that when you're interviewed, you're not interviewed just as a random individual. You're interviewed as a professional. So you have kind of I feel like I have kind of a duty to the profession. So I need to say things that are accurate and provide a value added that are not just general statements of no interest and advertise for the discipline. So that was the last experience that I got for long COVID. And I'd like to thank you for your kind invitation and attention for this talk. Thank you.